Welcome back, everyone, to this year's EMPH seminar series. We have a great lineup, as you can see on the channel, so please do subscribe and keep updated and get notifications. During the talk, you can add questions to the chat box, and then at the end of the talk, I'll read those out to our speaker. So today, we're very pleased to welcome the wonderful Professor Grazyna Jasienska of the Institute of Public Health at Jagiellonian University in Poland. Grazyna has conducted research and published on many overlapping topics in evolutionary medicine, and of course authored that wonderful book, The Fragile Wisdom, that inspired many of us to think about women's health in terms of environmental mismatch, and really how much more we can understand by taking an evolutionary approach to health. Grazyna is also the director and the PI of the Mogielka Human Ecology Field Site, where she and her research lab study many aspects of human behavior, evolutionary demography, aging, reproduction, and mate choice. But today, she's going to tell us why public health needs evolutionary thinking. I'm going to share your screen now, and over to you. Thank you, Grazyna.
Thank you very much, Paula, for this kind invitation to the series. Also, thank you to Gabriela, and thank you for your very nice introduction. Let me just share my slides in a different format. Is it okay? I guess it is.
All right. It's all good. It's all good.
All right. Thank you very much. I'm going to talk about, of course, as you could see my title, Public Health Needs Evolutionary Thinking, but I'm not going to talk, obviously, about entire public health. I'm going to concentrate on reproductive health of women, and also only on a selected aspect of this reproduction. I can promise you one thing, there would be nothing about COVID in this talk. So what we are going to do here, we are going to look at changes in reproductive health of women and examining some real changes that are already occurring or already occurred. And also some changes that are expected, whether those changes will really occur or not at the level of population. It's hard to say, but I will tell you why I think those changes are possible. So I'm going to be interested in changes that are occurring in low and middle income countries and changes that are in relation to recent trend in energy status. And I will tell you in a minute what I mean by energy status. So it is very clear that people are eating more and more. We are not necessarily eating better, but we are consuming more energy. And here I really want to say one thing, that I'm going to talk about some large trends that are occurring either worldwide or trends that are occurring in a selected region of the world. And I'm well aware of diversity, of variation, of inequality, but I'm not going to talk about it. I'm going to be concerned with what's going on in general when it comes to changes in energy, when it comes to changes in reproduction. So we could see that everywhere in the world where we are looking, all the region, in the last 50 years, there is a significant increase in how much we eat in terms of calories. At the same time, we are not really becoming more physically active. In fact, when you look here, and if you look at the very bottom panel, this is for the entire world from the year 2000 until 2017 or so, and the line is basically flat. So our physical activity is not changing. I should say that data for physical activity are very hard to find, in fact, surprisingly. So this is a specific aspect. This is a specific way of looking at physical activity. Or we are looking at something that's called insufficient physical activity, and we are looking at women. And there is very, of course, specific definition what we mean by this insufficient physical activity. And so looking at that and looking at different regions and seeing that there is no much change, we could say, well, good. So we are doing okay if this inactivity is not really increasing. But not really, because if you look at closer, you will see that in some regions we have up to 40% of women who have this insufficient physical activity. So situation with physical activity is not good. If we are eating more and we are not more physically active, of course, BMI is increasing. And we are seeing the increase in BMI basically everywhere in the world. We see men and women here, and you see lots of lines, and BMI, we are just getting fatter and fatter. And this graph comes from the paper that's done by NCD Risk Factor Collaboration. This is the collaboration of huge collaboration of many hundreds of people and researchers and research centers. And we are in fact a part of this. So we are contributing our Polish data from rural places. So, you know, our points are somewhere there contributing to those lines. We are very happy about it because there are many interesting papers that came out. But here we are seeing, well, we are getting heavier as adults. Babies are also getting bigger. This is a quite specific trend of getting bigger also, because please remember that we are mostly concerned with low and middle income countries, and I will get to that why this is important to stress out. And here we are looking at in trends in low birth weight and the recent change. So in the world, we have some decrease in percentage of babies who are born with low birth weight. This is very good, in fact, although this decrease is not overwhelming. There are some, in some places, quite a few babies that are born with this birth weight, which is not good for their health. But in general, we are seeing some decreasing trends in low birth weight. So in general, babies are getting bigger. If we are looking at some data from some countries, like in China, for example, we are seeing the average increases in body weight, body length, BMI, ponderal indexes like BMI for the baby, head circumferences, and so on. So babies in China got bigger. If we are looking at prevalence of macrosomia, macrosomia is defined as having a baby that's at least 4 kilograms of weight or more. And we see that there are increases in macrosomic babies in China. In Ghana, I don't know whether it was increasing, but I thought that this is an interesting data that shows that over 10% of babies are macrosomic. But it's important to say that in other countries, like for example, in the US, what in fact we have a increase in babies with low birth weight and decrease in babies with macrosomia. So, but this is less interesting for us because we are concentrating on low and middle income countries. Not only babies, but older children are changing. We see girls and we see boys in different countries, and just this is height, change in height in adolescence. And everywhere when colors are yellow, blue, or green, it means that children got taller. And the change in height is even up to 7 centimeters for girls and 9 centimeters for boys. Children are also getting heavier. Again, we have girls, we have boys, colors are different here, but everywhere where we are looking at yellow or orange or red, it means that children increased their BMI. Age of menarche is declining, and we are, probably many of you are well aware of those trends. Those are secular trends that were observed in European countries, very significant decline in age of menarche. But also in other countries, we are seeing similar trends. This is China between 1975 and 2000. And we see that age of menarche that was above 14 now is below 13. So those changes are not only in high income countries. So if we are seeing all those changes, that people are not undernourished anymore, we need to consider what it means. So, and since we are concerned is in with reproductive health, so we are going to talk about women mostly, and the understanding of being undernourished and reproducing and was such, and of course based on many data, and we know that this is true, that if a woman is undernourished, she will have small babies. So women who have either low body weight, or women who have low BMI, or women who are frequently losing weight or working physically very hard, are women who have at higher risk of having babies who are small. So if energy is important, that many people sort of concluded from that if a woman is undernourished, and if we are supplying this woman with additional energy, she will have larger babies. Yes? That sounds like a very logical assumption. And if you think it's logical, it is logical, but it's wrong. It's not what happens. I'm going to tell you about some studies, and I think perhaps some of you know about them already. If not, you should, because those are absolutely wonderful studies. So I'm going to examine 3 old studies, and then later on in my talk, I get to something else. But first, those old studies. So this is a study from the Gambia. And this is a study on supplementation of pregnant women. So what happened in the Gambia, in the rural parts of the countries, researchers observed that babies were born with a very small birth weight. There was a high percentage of babies with birth weight below 2.5 kilograms, so this clinically low birth weight. And the birth weight is a very strong predictor of health and mortality. So they also observed that there were seasonal food shortages in those villages, and during this seasons, people are eating very, very poorly. So in fact, the caloric consumption was about even only about 1,000 kilocalories per day, including pregnant women. So there is very, very little. So what they did this energetic energy supplementation study. So they selected a group of pregnant women, and they provided the supplements, and those supplements were giving additional energy of over 700 kilocalories per day. And later on, they also supplemented women who were lactating children. And they did that with a very clear expectation. So the idea was that if you give a woman additional energy, she will give birth to larger babies. And this is not what really happened. There was an increase in birth weight, but it was only 50 grams. So 50 grams is really, really little, and this is not what they were expecting at all. So, so those researchers thought, well, maybe the strategy of the organism of the woman, it's different. So when you are supplemented with additional calories, you are not really investing in a baby during pregnancy, but you're investing in a baby during lactation. But in fact, this is not true, because the milk output of supplemented women did not change at all. Composition of milk changed a little. There was more protein, less carbohydrates, but in fact, the energy content was exactly the same. Whether women were supplemented or not supplemented, it didn't matter. So what happened to this energy? Where this energy went? So what happened with energy was that supplemented women had shorter time until the next pregnancy. And this was really striking, because the extension, the reduction of this postpartum infertility, postpartum meaning after giving birth, infertility was by 35 weeks. So a really large difference between supplemented and non-supplemented women in how soon they were able to conceive again. Another study, this is a study from Ethiopia, and it's a study on reduction in physical work for women. This was done by Mary Gibson and Ruth Mace, and I'm really a fan of this study. I think this is really, really cool. And this was not any kind of intervention study, but the observation. So what was done here? First, it was noticed that in Ethiopia, during dry seasons, women have very high energy expenditure. They are doing a lot of work in terms of walking and carrying water. And during those dry seasons, women were often walking up to 30 kilometers per day, bringing water to the house. And then something wonderful happened in some of the villages, because the water tap stands were installed. And it was usually in the center of the village, just one stand, but it really changed life of women, because women now, after they had those stands, had reduced walking from on the average 3 hours per day to just 15 minutes per day. So this is really large change in energy expenditure that occur for women. And of course, it was expected that women who had access to those water taps would gain weight. Yes, so if you are decreasing your energy expenditure, you should become fatter, you should gain some kilograms. But there was absolutely no change in body mass index of women. So they are really decreasing their activity, and nothing happens in terms of fat storage of the body. So again, what happened to this energy? This is what happened to the energy. So we are looking here on y-axis. We have how many months a woman is since giving birth to a previous child. And on y-axis, we have a proportion of women who did not give birth for another time. They didn't give birth to another children. So this is how this looked before the water taps. So we could see, for example, that by 16 months after giving birth, most women are still not giving another birth. Yes, nothing is really happening, very, very, very low percentage. But with access to water taps, things did change. So, for example, by 16 months, 10% of women or so already are giving birth to another child. And this difference continues. This difference is still visible months after months after months. So we see that with reduction in work, women had shorter time until the next pregnancy. And again, the difference is quite large, because women who had reduced workload were more than 3 times as likely to give birth in a given month than women who did not have any access to water tubs. Study number 3. This is study done in Guatemala, and this is also a supplementation study, but it's sort of the different kind of outcome that we are interested in here, because this is a supplementation during fetal life and early childhood. So women are supplemented as fetuses and young children. This was a long-term supplementation study, meaning the supplementation itself lasted for several months, but the outcomes of the supplementation for many years were research for many years. So, but at the beginning, people were just randomly selected to receive 2 different kinds of supplementation. So everybody got supplementation, but some people got Fetal, which was very good supplement with high energy and high protein. And some people got Fresco, which was also a supplement, but not as good. It has lower energy, did not have protein. Both have exactly the same vitamins, minerals, and were consumed twice a day. So almost 1,000 women were supplemented during their own fetal development and during the first 3 years of life. So we have a really large sample here. And about 24 years of follow-up. So we have a lot of data about these women, but I'm just going to show you a few things. So we are going to look at their age at menarche, age at sexual initiation, first pregnancy, and first birth. So to remind you, Fetal is a good supplement, Fresco is poorer supplement. So we are comparing groups of women who got either one or another. So there are no differences in age at menarche, but in all other aspects of reproduction that we are looking at, there are differences. So women who got better supplement had shorter time from menarche to first intercourse. They had shorter time from first intercourse to first birth. They had shorter time from menarche to first birth and earlier age at first birth. So just comparing better supplementation with poorer supplementation resulted in all those changes in reproductive pattern. Remember, we are not comparing women who are not supplemented at all. Probably if we did that, the differences would be even larger. So what connects all those 3 studies? Obviously, the fact that women had more energy, either by having more food or by working less, but just the body physiology received additional calories, received additional energy. And energy is absolutely crucial for reproduction. Of course, pregnancy is costly, breastfeeding is costly in terms of energy. Thus, the organism needs to really make decisions when to invest in the next reproduction based on a clue about energy and environment. So here we are looking at ovarian function, and ovarian function is basically what's going on during menstrual cycles in women. So production of hormones, production of estradiol and progesterone, two hormones that are crucial for getting pregnant. And obviously ovarian function is determining fertility, determining the ability to get pregnant. And ovarian function in turn is very sensitive to energy. So, and it's energy during all stages of life. So we know that energy during fetal development of a woman, her childhood development and her adult life are important for how ovarian function is, what's going on with ovarian function, how hormones are produced, whether cycles are ovulatory or not, and so on. So let's look at the adult environment and few factors that are important here for ovarian function. So this is the old study, again, coming from Peter Ellison's lab, but basically the first study in which hormones were really measured very carefully. So every day during the cycle, women were collecting a saliva sample, so we really know what's going on during those cycles. And this is a weight loss study. So yellow profile, this is progesterone profile, comes from women who were dieting. And those women reduced their caloric intake and lost on the average just 2 kilograms of body weight. So this is a very small change in body weight, but still this change in body weight resulted in suppression of progesterone levels in comparison to women who were in a control group and they were not losing weight. Another study from Ellison's lab, this is the study on exercise. So women are jogging, and again, we are looking at the level of progesterone and comparing this level of progesterone with women who are non-physically active. And we can see that in joggers, progesterone is suppressed. And again, this is jogging that's just like in a weight loss, we observe just a little bit of the weight loss. This is a jogging that's clearly only recreational. So this is not professional exercise that we are talking about. Obviously, professional exercise have the same effect and even stronger. But what's important here is that even recreational exercise has this kind of effect. But still, you know, when we are thinking about the low-income countries, middle-income countries, we could ask the question, well, perhaps, you know, recreational exercise is a luxury that not many women can afford. So maybe this is not really relevant when we are trying to understand what's going on in real world, yes? So we did the study to understand this. We did the study in Mogielica Human Ecology Study Site when we are working for a very long time now. This is rural Poland. And when this study was done, basically everyone in the villages that we are working with was doing some kind of agriculture. And this is a small scale, work-intense agriculture. And women are doing a lot of physical work during some seasons of the year. So this is harvest season, and harvest season is a very intense work for women. So what we did, we decided to look whether physical work, not exercise, but physical work, has effect on levels of hormones. And it does. So here we are comparing progesterone profiles of women who are either working very hard, this is a white profile, with women who are not working that hard in 2 consecutive summers. And in both summers, we see that there is a reduction in progesterone level in those women who have high levels of energy expenditure due to physical work. So now let's look at fetal environment and how fetal environment affects ovarian function. We look at one aspect. Of course, you know, fetal environment, it's very hard to study. Yes, one thing that we can do, we can look at size at birth of babies. And based on size at birth, we could sort of guess what was the maternal environment in terms of energy. And so we look at the ponderal index as an indicator of newborn's nutritional status. And ponderal index is something very similar to BMI, so it's a fatness of the baby. And we compare groups of women who were born with different fatness and look at their estradiol levels when they were adults. So this is estradiol in menstrual cycles in adult women who were born with different sizes. And what we see here is that women who were born as relatively skinny babies, this is the yellow bar, have lower estradiol than women who were born as relatively fat babies. This is this dark orange bar. So from that, we could conclude that early environment, fetal environment, is also important determinant of ovarian function of adult women. So coming back to the Gambia, Ethiopia, and Guatemala, in none of those studies, of course, reproductive hormones were measured. We don't know anything about reproductive hormones. In Gambia later on, yes, but different kind of measurements with different questions related to lactation and not to things that we are talking about. So reproductive hormones are not measured, but I think that the observed effects were most likely mediated by changes in levels of these hormones. I don't know any other explanation. So all those women had more energy. And if a woman has more energy, she has higher levels of hormones in the menstrual cycles. And if she has higher levels of hormones, she has higher chance of pregnancy. And in all those studies, we show that women who were better, who had more energy, had higher chance of pregnancy. I should mention that, of course, there are some other supplementation studies. So it's not that I selected those that work and support my ideas. And in some supplementation studies, we see some kind of improvement. When we are supplementing mothers, we see that babies are bigger. But it's a very sort of mixed results. And for example, there is a study that show some improvement in birth weight, but the improvement is only about 3%, a little bit than 3%. So the question is, this was statistically significant, but is 3% difference biologically significant? In another study, infants of women who were mothers for the first time had higher birth weight. And yet another study, boys had higher birth weight, but there was no difference for girls. So sometimes supplementation works. It's not like supplementation is absolutely not working. But in general, supplementation is not working as we expected. We are expecting large changes. If we are supplying women with a lot of additional energy, we are supplying significant changes when it comes to birth weight, and we don't see that. And the question is why? There are different reasons for that. I think the one is that we should be thinking about their long-term reproductive strategy, because this is probably what the physiology, what the organism does. So the organism of the supplemented mother is sort of thinking about how to divide this energy to consecutive children and not just to this particular child. So long-term reproductive strategy is probably important. There are trade-offs in energy allocation to competing physiological functions. So the organism could make a decision of investing in a baby, but it could invest in maternal energy store, or it could invest in maternal immune system, because mother in better house could produce additional children. There are clearly trade-offs between what we like children's quantity, how many we have of them, versus children quality, if you will. And so especially in high mortality environment, better strategy could be to have higher number of children rather than one or two in very good condition. And also developmental history of women is important. So the response of the organism could depend on this information that the organism received during their own fetal development, during childhood development, and even intergenerational information. So in what condition mothers and grandmothers were developing, and the strategy and investment could be different here. So a lesson from evolutionary biology here is that a woman invests in a lifetime reproduction and not really in a single reproductive event. Of course, the single reproductive event is important, but the long-term reproductive strategy is crucial. So we see that often additional energy is not used to improve the condition of a child, but this energy is used to have another child. This is what we see in Gambia, in Ethiopia, and probably in Guatemala. One more study, and this one is very recent, in fact, and this is cool study, and I was so happy to see it. So when I was in fact asked to write a commentary about it, I said immediately, I said yes, and I will tell you why. So this is a study on looking at data sets on 2.7 million sorry, there is a typo, million births in 84 low and middle income countries. And they did that in order to understand the relationship between breastfeeding duration and postpartum amenorrhea. Amenorrhea is the lack of menstrual cycle. So postpartum amenorrhea is for how long women are not cycling after giving birth when they are lactating children. So this is what the study show, and this study is really worth checking because it has many more than what I'm going to show you here. This is especially striking for Asia, less to sub-Saharan Africa. But if you look at Asia, the upper graph, what we are looking at? We are looking at time that since giving birth to children, 6 months only. And proportion of women who are amenorrheic, so women who don't have menstrual cycles. And we could see that this is really changing over the years. So like in 1993, by the month 6 after giving birth to a child, probably how many? 70% of women still did not have cycles. 2015, only 50% of women did not have cycles. So something is changing. The breastfeeding is not as effective as it used to be. This is sub-Saharan Africa, and here there are also some differences, although they don't look as spectacular. However, they look spectacular here. So the next step in this paper was to divide women in what the authors called low development situation and high development situation. And low development, those were women who had rural residence, no electricity, had to walk for water, and had no maternal education. And when we look at sub-Saharan Africa, we see that, again, we are looking at the duration of breastfeeding and duration of amenorrhea. And now for over 30 months, duration of breastfeeding for a long time, 30 months, yes? And we see that for those women who have this low development situation, the relationship is much steeper. So those women still respond with amenorrhea to breastfeeding. But women who have this high development situation are not responding as well. They are breastfeeding too. And what's important about this paper, that what they did, they look at only an exclusive breastfeeding. So all women are exclusively breastfeeding for those 6 months. Later on, of course, nobody's breastfeeding exclusively, but at the beginning is just exclusive breastfeeding. And for Asia Pacific, there is also similar relationship, although not as strong. So breastfeeding has much weaker effect on preventing the next pregnancy than it did in the past. So, and I think that better energetic status of women is responsible for this weakening effect. Breastfeeding, of course, what do we know about breastfeeding in our ancestral, in our hunter-gatherers ancestors? Well, we know, for example, there is a paper based on by Mel Conner based on Kung from Kalahari Desert, and in this paper it was shown that Kung had very long duration of breastfeeding, about 3 years. Very frequent nursing episodes of about every 15 minutes the baby was given some milk, and extremely long interbirth intervals of 44 months. But there is another interesting population. There used to be hunter-gatherers. They are now settled. They are called Toba and live in Argentina, and studied by Claudia Valegia and Peter Ellison. And in this population, we have lactation or amenorrhea for a little more than 10 months and interbirth intervals of about 24 months. And of course, here we could ask the question, all right, so they were hunter-gatherers, but they are not hunter-gatherers anymore. But in fact, when we look at the pattern of lactation, they are still hunter-gatherers, because this is the infant's age, yeah, so we are looking for up to 18 months, and we see that infants are nursed about 4 times an hour. So just like very traditional hunter-gatherers. So the pattern of lactation in Toba is exactly the same. So why do we have such a difference between Kung and Toba in interbirth interval if they are lactating children exactly in the same way? So the answer is we have a difference because those women are in a very different energetic status. Toba have much higher BMI than Kung, and also this study also looked at BMI and energy balance as a factor related to resumption of cycles after giving birth during breastfeeding. And what they show here, they show that cycles are basically beginning after women are really reaching a positive energy balance. So after giving birth, women are in a negative energy balance. Then this energy balance is sort of neutral for a while, and once it becomes positive, cycles begin. So energy is absolutely crucial. This is another way of looking at this. This is C-peptide marker of insulin, and it basically showed the same, that energy is absolutely crucial for resumption of cycles in women who are breastfeeding. So duration of lactation or amenorrhea depends on duration of breastfeeding. It depends on a pattern of breastfeeding, but it also depends on nutritional status of the mother. So it's not enough to breastfeed for a long time. It's not enough to breastfeed frequently during the day, but it also how much energy a mother has is important. So improvement in women's energetic status, of course, may lead to higher number of pregnancy. We saw that, but there is more, in fact, when it comes to this improvement in energetic status when we are observing all around the world. And this has to do with breast cancer. So breastfeeding is a breast cancer protection factor. And we know that breastfeeding suppresses ovarian activity, reduces number of cycles. And previously people thought that long breastfeeding means long lactation or amenorrhea. Now we know that this is not quite like that. Long breastfeeding could be related to much shorter lactation or amenorrhea than before. Should we worry about it? Well, yes. This is the breast cancer incidence in different regions in the world. And obviously, high-income countries have the higher incidence and low-income countries the lowest incidence. But in fact, breast cancer is increasing everywhere in the world, almost everywhere. In high-income countries, sometimes is decreasing. But if we are looking at the upper panel is the incidence of breast cancer. And especially look at the bottom here when we have things in yellow, those are low-income countries. And you see that even in low-income and middle-income countries, incidence of breast cancer is increasing. The lower panel is mortality. And when we look at the mortality, we see that, in fact, in high-income countries, mortality is decreasing. But in low-income country, there is an increasing trend in mortality. So not only women have more breast cancer, but they are more often dying of the breast cancer. And just annual change in breast cancer incidence, everything that is red in this table means that breast cancer is increasing in different ages and so on. And the lower table shows that fertility, declining fertility does not explain fully this increase in breast cancer. Of course, we know that number of children is this factor that prevents breast cancer, but it does not explain the difference as well here. So coming back to energy and ovarian function, and now, of course, this ovarian function is also crucial for breast cancer rate, because levels of reproductive hormones, especially estradiol, are clearly connected to breast cancer development and breast cancer persistence and so on. Other hormones that are also related to energy, like insulin or insulin growth factors, are also important here. So risk of breast cancer clearly increases due to the excess of metabolic energy and to high levels of lifetime levels of exposure to sex hormones, especially estrogens. And of course, the energy and hormone levels are closely connected. We saw that already. When we think about breast cancer risk factors, some of those, a very important one, that would be age of menarche, age of menopause, a number of children, duration of breastfeeding. And interesting, those factors are also life history traits. And in high energy environment, what we are observing is that if women have more energy, that the age menarche is early, age at menopause is later, number of children is high, although of course in modern society that would be fecundity, so the ability to give birth to children and not the actual fertility. Levels of reproductive hormones are high, levels of insulin and insulin growth factors are high, and duration of breastfeeding is short. So this is the high energy environment. And it works like that probably because this strategy leads to higher reproductive success. It speeds reproduction, it speeds giving birth to consecutive children. So this is just high reproductive success that we are talking about. We can also ask why women have high lifetime levels of estrogen and progesterone. And of course, women have high exposure to those hormones because they have many menstrual cycles, because they are having early menarche, late menopause, they don't have children, and they are not breastfeeding or breastfeeding for a short time, or breastfeeding is not effective anymore. And also because they have cycles with high levels of hormones, because they have more energy. So breast cancer prevention can be achieved via reduction to lifetime exposure to sex hormones. But question is how? So menarche and menopause, it's very hard to change those ages. Pharmacologically and through lifestyle changes that could be done, but that's very unlikely that this will happen. Parity, so having more children just to have protection against breast cancer, not many women will do that. Breastfeeding, increasing the duration of breastfeeding, well, some women will probably do that, but breastfeeding is not very effective anymore in women who have good energetic status. And physical activity is also, of course, could be a good way of reducing this exposure to sex hormones, but here we also have a problem. So we know that physical activity reduces levels of estradiol and progesterone, but fetal environment also here comes into play and affects ovarian function, as we were able to see. And those two environments are working together to influence the levels of hormones. And what's going on, in fact, is that the power of physical activity to reduce estradiol may depend on size at birth of the woman. And here what we are looking at, the most important thing are the yellow bars. We are looking at women who are born either as small babies or large babies, and we are looking at their estradiol level. And what we see here, the yellow bars are women who have moderate levels of physical activity. And here we see that in women who were born as small babies, those moderate levels of activity are enough to suppress estradiol, but in women who were born as a large baby, those levels are not sufficient. So physical activity as a factor to reduce breast cancer is, again, its effectiveness, it's not always there. So improvement in energetic status, as we show in a population, may lead to shorter interbirth intervals, may lead to unwanted pregnancies, poorer health of infants, poorer health of mothers, sort of maternal depletion, and increased risk of breast cancer. But still, I would say that nutritional supplementation of women and children is needed. That's obvious, that if women and children don't have enough to eat, they should be supplemented, they should be given food. However, I think that evolutionary perspective suggests that the public health intervention that we are doing in the area of maternal and child health should be comprehensive. They should provide knowledge about family planning, access to contraception, and strategies for breast cancer prevention. So just feeding people is not enough. It should be a really comprehensive program that, because only program like this will lead to improvement in health, rather than seeing some unwanted side effects of our interventions. So in concluding, I just want to show you a wonderful team of people I'm working with. There are many people missing from here, people who are contributed data to those data I was showing you. But this is people that are currently working with me in Krakow. And with that, I would like to thank you very much for your attention, and thank you.
Thanks so much. That was great. Super fascinating. I hope it wasn't see your audience. We're just waiting for some questions to come through, but I really want to pick up on the paper that you were just referring to. So, well, this last slide where you talk about how to make this holistic program, right? So you don't just have a TAP or a nutritional supplement. You need to, target the thing from many angles. And I love the study of Murray Gibson and Ruth Mace in Ethiopia. I teach it in my classes, and of course the supplement studies too. So they're obviously quite old studies, and I'm just wondering if you know what has happened since. Like, do these other things like the contraceptive information and access and sort of family planning advice, this kind of thing, have there been public health interventions? Have the local centers come and said, okay, look what's happened, we need to now, like, what has happened since then, I guess?
So, there are, of course, many public health interventions, but, Millennial Development Program, yes, that was done in many countries and focusing on reproductive health. But the focus of this was, it was in fact working in some aspects, criticized in other aspects, because there were things sort of, I think, done separately. So we are introducing contraception and family planning. We are concentrating on increasing breastfeeding. We are, improving maternal visits to when the women who are pregnant or women who are giving birth to babies. And even though the sort of the idea was to have this as a sort of entire reproductive health, I think that still things were done sort of separately. And I'm not sure if there were like really large intervention. People are usually supplemented either in when there is a study done, yes, there is a supplementation, or people are given food when there is a crisis. And obviously, when there is a crisis, you don't think about other things, and because you shouldn't, yes, that there is a crisis, and you need to feed people, and that's what's important. So I'm not really aware of any. Maybe people are aware, but I'm not really aware of any, like, very sort of comprehensive intervention that we will look at all aspects of what's going on.
But this is why public health needs evolutionary medicine or evolutionary thinking. I have a question here from Rose Stevens. Thank you very much for the fantastic talk. Would you recommend using hormonal contraceptives to suppress natural cycles and maintain low hormone levels over the longer term to reduce breast cancer?
I would not. No, I would not. Those ideas were there. I think they are probably gone, but they were ideas like this in the 90s, when not really to cycles, but to postponing cycles in adolescence. And the idea was to either give girls contraceptives in order to not really have the menarche early. So you start with young girls. Some ideas also was that every girl should be in doing some really intense physical activity, like ballet or running 20 kilometers a day or so on, in order to postpone menarche. So I don't think any kind of sort of pharmacological intervention. I don't like the idea. Also, we still, contraception been with us for a long time, the hormonal contraception, and it's still not working very well. The contraception is not really it was designed for women from the US and Western Europe based on their own levels of production of hormones. And hormonal contraception still doesn't work very well for women in Southern America or in terms of side effects. So it's not really, I think the idea is study normal hormonal production first, establish what it is, and then design a hormonal contraception specifically for women like that. But I talked once to somebody who was working in a pharmaceutical company and was responsible for contraception worldwide, and she had no idea what I'm talking about, in fact. That there are differences between populations in levels of hormones that women produce. So I'm not sure.
Thank you. All right, quite a few questions. So it is clear from your examples that exercise and nutrition have a huge effect on age at menstruation and interbirth intervals. I'm curious if you have any stress as well. What of a well-fed woman who lives in an exceptionally stressful environment?
That's a good question. And, there is a study that we did when I was working in a Peter Ellison's lab, when we were trying to really answer this question, whether stress has any psychological stress, whether it has any effect on production of hormones during cycles. And we look at short-term stress and we look at the chronic stress. So short-term, were in women who are taking the MCAT. This is the exam that women in US are taking when they want to go to the medical school. And this is very stressful. They are preparing for this, and it depends. Your score determines whether you are going to get to medical school and whether this is a good school or not. So it's really stressful. It did nothing to hormones. Also chronic, the chronic stress. So there are some people who are always stressed, and there are also people who are really relaxed. It also really, there was no connection with either estradiol or progesterone. But there are some studies, in fact, that are showing that women who are going through sort of relaxing therapy and so on are able to conceive, even though they had problems before. So there is something going on with stress, but I'm not sure if I believe that this really affects hormones.
Thank you. Rebecca Britton asks, has anyone looked at the effects of macronutrients on ovarian function or ratios? Or does total calories seem to be the most important measure?
Great question. Great question. I don't know. I'm not aware of any new study. We did that. We did that in Poland. One of my former grad students, Anna Merklinger-Gruchała, did a PhD study on this. And so we had, during the entire cycle, women were keeping the diary and they were telling us what they were eating and so on. So she looked at micronutrients and vitamins and minerals and everything, and nothing mattered really. But this was just our study, and I'm not sure, maybe there are some other studies that are showing different things. But for us, no.
How or why do higher absolute hormone levels lead to higher chance of pregnancy or fecundity? Do you think that is the only mechanistic path between energy and fecundity? The high.
Well, why? I'm not sure if this is the question, whether we have a data for this, so let me answer this like that. That we know that cycles that have higher levels of hormones are estradiol, because progesterone we cannot study, because once you get pregnant, your progesterone goes up, and so you cannot study the effect of progesterone on differences in progesterone. But with estradiol, yes. And again, great study that was done in Peter's Ellison lab, in which they were looking in women who were attempting to get pregnant. And some women got pregnant, some did not. It was going on for 12 months and so on. And then it turns out that those who were able to get pregnant had higher estradiol in their cycles. So the estradiol is the hormone that allows for higher chance of conception, higher chance of fecundity. Oh, I see the question also. Do higher absolute levels lead to higher chance? Yes, they do, especially, absolutely. Of course, we are not talking about anything, pathologically high, yes? It's the only mechanistic between energy and fecundity. There are, of course, other hormones, but I think those hormones, mostly like insulin, yes, insulin would be, this is the hormone that tells the organism what's your energetic, because how do you know what's your energetic status? Insulin is one of those wonderful hormones. People were very excited about leptin and ghrelin, but I think for ovarian function, insulin is probably one of the most important hormones. But insulin gives a signal to the ovary. So, and then the ovary produces higher or lower levels of hormones depending. So I think this is probably I'm not sure if this is the only, I think this is the most important mechanistic path.
Thank you. Gabrielle is asking, I'm wondering if you have any idea of what happens if you reduce exercise and increase food for a very long time. Do you think after the interbirth interval reduces that only then the babies become big?
This is a very good question, because I think that it's very important to distinguish between something like a short-term, what's going on in the short term and the long term. So the short term, this is something that we are observing like in supplementation studies. So we are having women who are doing poorly in terms of energy, in general, in their entire life, basically, yes? So the Gambia, they are just energy stressed always, sometimes more, sometimes less, but they are basically always energy stressed. And we are giving them this additional energy. So we are looking at something that's very short term. And I think that's very different from the long-term response of the organism. And the long-term response of the organism could be different, because this would be something that would be based on your experience, this long-term experience. So what kind of energy you had when you were a baby, what kind of energy you had during your fetal life, during your childhood, what kind of energy the previous generations had. And so through maybe epigenetic, this intergenerational signal, and I think the responses could be very different. So I'm not sure if I'm answering Gabriella's question, but I'm glad that I had a chance to say that, because I think this is also something that we don't understand very well, but I think it's interesting and important.
What is your point of view on polycystic ovary syndrome as an evolutionary adaptation?
Bernie Crespi would be a wonderful person to ask about that. I think he's going to talk, yes?
Yes.
So I read his paper, but I'm not going to tell you anything about it. So you come to listen to Bernie, because he has great ideas, and I'm not an expert on it. So if you excuse me, just wait for Bernie's talk, because I think that you should not miss it.
Thanks for the plug. Yes, I'm really looking forward to that as well. I guess I have a question about, because a lot of this research, of course, is done, as you said, in resource stress situations. And so what can we, I guess this is a more bigger overview question about evolutionary medicine and public health in our sort of society, you sort of ticked a lot of boxes of the things that are quite hard to change, and you know, we can't breastfeed for longer if we're not having babies and so on. So you know, just your general thoughts about what we can do in Europe.
You know, I always thought that you know that physical activity is the best strategy, and I still think so. I just think that it's not so it's not one prescription that fits all, because the how much physical activity a woman needs depends on another things. Whether if we want to prevent breast cancer, yes, so the lower exposure to hormone levels. I think physical activity is still the best thing that we can do. But you know, we are just doing the study in Poland now. Stopped. We had to postpone because of the pandemics. But that's exactly, we are again looking at this question: how exercise, which is really influence levels of hormones in women who are different than women we studied before, because you know the some data that we have are in fact from women. We did study in early like 2002 or so, and I think those women, through their intergenerational experience, were different than young women who we have right now. So I want to see whether exercise still has this suppressing effect on ovarian function in women, and know a little more about how much of exercise a woman should do. But I think this is the best strategy. Another strategy, you know, is a weight loss, but you know, who wants to do it all the time? Weight loss will you know work too, but but exercise is much more pleasant, I think so.
We hear a lot about fears of hormones in meat and in food. Is this something you think could start to be an issue? Granted, it happens more in the US than in rural Poland, or perhaps not quite your area.
No, I think I think the hormones are a concern. And you know, exactly not my area, but you know, I read papers, and you know, people are very concerned with exposure to those hormones, because those are you know, growth hormones and some other things. Exposure to for children, exposure during fetal life, if mother has a high intake. So I think this is this is clearly something that's that could be problematic. Another thing is sort of exposure to all those estrogens that comes from the environment. Yes, so that's even more probably than hormones in meat. But those estrogens are also in meat, because the animals will also consume some of those things. So I think that's those hormones that are sort of not produced by the organism, but coming from outside, that are interfering clearly with the hormonal production. How in different ways, because if they affect so like environmental estrogens, for example. Yes, environmental estrogens, they are usually not estrogens, but what they do, those chemicals, they are able to bind to estrogen receptors. So the organism thinks, well, I have estrogen, so our own production of estrogen could stop because of that, because we already have it, receptors are bind. So this could lead to infertility, and some people are saying that this is already occurring. So I think in general, hormones are either in meat or plastic or things like that are a concern.
Thanks so much. I think that is all the questions we have. That was a really brilliant talk. Thanks for everyone who tuned in. Next week, we have Steve Stearns, who's going to give us a talk about the highlights of evolutionary medicine over the couple of last decades. So tune into that as well. And I will say goodbye to the YouTube audience right now. Thank you. Bye-bye.